Hi, everyone, and then welcome to our summer learning session 2025. So the topic of our summer learning session is the culture of care, embracing rooted, elevating practice. This is a third presentation. It's today, August 21st, 2025. And then in our next slide, we want to acknowledge that this program is funded by Maine Department of Health and Human Services, Office of Behavioral Health through Pediatric Mental Health Care Access. So it's also in collaboration with ERSA. And then this learning session is prepared by MCD in collaboration with Maine Pediatric and Behavioral Health Partnership. So the session, let's go a little bit in our housekeeping. All participants are muted, and then the webinar is being recorded as we are doing right now. For someone who will miss this part, we could just send a link and the passcode. And we already have a live transcript. It is available from our Zoom, and you could just go in your more. But if you did not find it, we have 3 dots. You could just click in that 3 dots and you will see a caption, and you could just control your transcript in the language you really want. Also, we have a type, any question in our chat, or you could just unmute yourself in Jump and then ask your question. Please use the Q&A question button for technical issue. If you have any technical issue, did not hear us, or your video does not work, you could just go in question and answer, put your technical issue there, and then we'll take care of. Also, at the end of this webinar, we will ask you to take just 2 minutes to answer to our evaluation question, and then it will be just required. Let's go just in our next slide. This webinar session, it will be in partnership with Maine Department of Health and Human Services. We have Maine Pediatric and Behavioral Health Partnership. We have MCD Global Health, who just provide us a platform and all material and logistic. Also, we have the Immigrant Resource Center of Maine, who will be one of our partners and will give us a presenter of the day. So for today, the topic is clinical approach to sensitive health discussion. This will be held and presented by our great leader, Fatuma Hussein, who is a founder and executive director of Immigrant Resource Center of Maine. So Fatuma, if I forget maybe any presentation, you could add and start your presentation. Thank you so much for everyone. And then Fatuma, you have a stage.
Thank you, Axel. I'm going to do one more time my sharing. That way I'm not... maybe not that. Sorry. I keep messing up. Wait. One more time. How about this one?
I believe it was the previous one, Fatuma, and then you click the slideshow.
Okay, sure. Oh, man.
Perfect. It's on slideshow already.
It's on slideshow already. I need to get my speaker notes though, so. Are you good with that?
Yes, we can see your slide.
And not my notes, right?
No, not your notes.
Okay, thank you. Welcome. I apologize for the technical difficulties. My name is Fatuma Hussein. I am with the Immigrant Resource Center of Maine. And I'm going to go very quickly. The slides are going to be available to you later on. I think, Christina, I feel like we have gone into our time, so I'm going to go very quickly with some of these things. Welcome to the Clinical Approaches to Sensitive Health discussions. This is an intercultural competence systemic transformation, and the practical tools for healthcare teams to support and meet the needs of diverse patients. I think it's important for us to also understand that the evolving of our state for the last 50 years, more so for the last 25 years. And what happens is you need to really change systems with the needs of the people and transform access and put tools in place like cultural competence and cultural considerations. I don't believe someone can be competent in someone else's culture unless you're part of that. But cultural considerations and getting the practical tools to support you and the community is what we're going to talk about today. I wanted to sort of use this opening segment to welcome all of you and to really say that IRCM's core philosophical foundations are really making sure that the values, the vehicles to drive the work, which means collaboration, partnership, trainings, all of those things are really encompassed in what we do in addressing the complex and unique needs of diverse clients, patients, people who really have needs are coming from away, and this is not the systems that they're used to. And all of that is to ensure that people's dignity, equity, and healing is actually centered. Um, the other goal for today is really this sensitive and vital thing that we need to talk about, which is to equip each of you with making sure that healthcare teams, including community health workers, social workers, case managers, medical assistants, doctors, nurses, and beyond, that whole ecosystem is really getting the interculturally competent and responsive practices that are essential to navigating sensitive health topics. This is a culture and a community that we can talk about a bunch of things, and there's a bunch of things that we can't talk about. We will explore how cultural contexts shape health, invisible illness, such as mental health, and people can't talk about that, and really making sure that there is, that collectivism, like this community is a community that we do something together and we do everything together. And whereas American culture teaches you how to be individualistic, it's about you. You get yourself whatever you need first and then think about anybody else and everybody else. And so if these two cultures are very opposite in terms of how they think, imagine accessing services and those systems. It's super important for us to also note that systems are made by you and me, right? Like systems are not things that are just whatever. We talk about systems, the healthcare system. There's a lot of people in the healthcare system that make decisions on behalf of each and every one of us every day. Most importantly, we'll show you how the IRCM's unique frameworks and models serve as a powerful vehicle to address these complex challenges and meet the unique needs of everyday clients. I'm going to be very like fast as much as I can. One of the things that we really need to talk about is this idea of the core foundation of impact and for impact. What are the things that we do? We look at our human dignity framework. I think in Maine, as coming to Maine, and I came to Maine 25 years ago. There is a piece around who are you, why are you here, and it's like, no, I have the ability to stay here. I don't need your permission. I can stay here, but let's all work together so that there is an identity in service delivery for me. And so we're going to apply that sectional understanding, recognizing that individuals carry layered identities, their race, gender, class, immigration status, all of which profoundly impact their health experiences. This framework also helps us see the whole person, not just a diagnosis. And we want to slip through this again one more time. So we had some poll questions, and maybe because we have a small group, maybe we can just do like, show of hands. One of the things that we wanted to talk about is this idea of what does it mean to what are the biggest challenges in sensitive health discussions with diverse patients? And Christine, I can't see people. I can see only my slides. And so I just wanted to just show by hands, ask these questions. I have a question for you. What are your biggest challenges in having sensitive health discussions with diverse patients? Uh, you know, and I can't see the screen, sorry, but I wanted to just check in with people to just come off mute and say, what are the biggest challenges that they see? This, lack of communication, is that communication barrier, lack of systemic supports? Are there other challenges? Are there addressing invisible illnesses that you see? How do you navigate family involvement in decision-making process?
Yeah, Fatuma, I know you can't see the participants, but you can also pop in anything in the chat and I can read that for Fatuma.
Okay.
But feel free to come off mute if you would like to
Thank you.
answer.
Yes.
Yeah.
That question paused. Yeah. Any takers? Afra? Anybody? If
You have a comment in the chat from Zakia. She says lack of systemic support and resources, especially with regards to primary care access.
Okay. Zakia, do you want to say something more about that? A little bit more about that?
Yeah, absolutely. So I would say in my experience as a community health worker working with diverse populations, that has been probably the most difficult or the biggest challenge that I've encountered when it comes to getting primary care. I mean, there really aren't a lot of primary care providers. People are on wait lists, and with regards to sensitive health discussions, whether that's vaccinations or reproductive health, it really helps to have primary care because that is the provider that you're seeing consistently, that understands your health information and your history and is able to kind of walk you through that process. And so if people are going to urgent care or the emergency room for their care, they're not getting that primary care that's supporting them through these sensitive discussions. And so they would just rather not have those conversations at all. So, I mean, when you have that lack of systemic support or the resources are just not there, it makes it really difficult for people to kind of approach these discussions and be proactive about it.
Thank you. And I think you're speaking to a very good point. I think there is this idea of, uh, yes, Ifrah, let me respond to her and then I'll come to you. Is that okay? Thank you, Habo. So I think there is this idea of in America, from the time you conceive a child, there's prenatal care, there's all kind of access to healthcare. Now it's not given, for all, but a lot of people do have that, or this at least the social systems are designed to be like that. Where we come from, those services also exist. But I think in this country, there is if a child is in school, for instance, they have to be vaccinated, they have to have their physical done on annual basis. There's a number of things that you have to do because there's a child welfare system. There's all kind of stuff that really protect the minor, right? What you're talking to also is this idea of our girls when as they hit puberty, where we come from a culture where nobody can talk about anything, right? If you're in mental health crisis state, whatever it is, it's a taboo to talk about that. And so a healthcare provider, for instance, I have a bunch of girls, and when they hit the age of 12, I want to go into the physical room with them and figure out their physical. And the doctors are saying, look, she just hit puberty. You are a mother. We know that, but can you slowly get out so that we can talk to them? I think that is something that is such a taboo in our culture. I remember years ago, a girl who had FGM, female genital mutilation, who was barely 14, who, there was all kind of stuff going on at home, domestic violence and all of that, and did not know how to navigate that. And nobody caught what she was going through, so much so that she got infected. She didn't know how to use a pad. So those kind of things are very sensitive. And today what we're talking about is to try to give providers a little bit of tools for them to understand how to navigate that. Ifra.
Yeah, I just wanted to add a little bit to what you guys were saying. Exactly that. I was interpreting for a family, and basically it was exactly that, those sensitive topics that the parent doesn't want to talk about it. And it was a teenager who was 16 years old, and the provider was asking questions about, like, do you have a boyfriend, and have you like, and so the parents were extremely angry because of the cultural thing. They are like, how dare you asking my daughter such a disrespectful question. And they are like, well, this are screenings that we have to do for health, but the parents was extremely, there was just like a huge disconnect between the parent and the provider because of the sensitive topic that was being discussed.
Right, right. Thank you, thank you. And the idea is we are actually moving forward in terms of systems who need the appropriate tools, but not hindering the access to sensitive topics and sensitive needs, partly because we have a lot of kids who are born here. My children and me are not from the same cultural lens. They were born here. This is a cultural lens. And here is a very rigid Somali mother and going into a primary care setting where girls are being asked, did you get your periods? I'll like hinge. Like, why would you ask that question? That is not a public question. And I think the ability to give providers, not necessarily not to ask the questions, we want them to ask the questions, but we also need providers to ask the questions in a way that acknowledges the person's identity, supports, the education moments that are needed, and give the provider the tools that they need so that the patient can get the best services that they can ever get. So I'm going to skip this. I mean, we're talking about this, which is good. I'm going to skip this because I'm looking at time too. And so I think let's begin by defining what we mean by sensitive health topics, right? These issues are issues that really are personal, they're emotional. We're talking about mental and physical health, community health, that are often becoming challenging to discuss due to deeply ingrained cultural norms. I think there's a stigma to anybody saying that I don't feel myself, there's something wrong with me. There's a huge stigma around that. I think there's a lot of lived experiences that we are not prepared for. Our kids are exposed to a culture that does not see any of their identities in it, like nothing, whether it's cultural norms, religious norms, but this is their identity. And then they come to a home that doesn't understand what they're going through. I came to this country when I was very young. I didn't have parents here, and it's very contradicting. It's very confusing. And if you're not able to really see through that and get the support systems that you need, you're not going to be successful. You're not going to be, healthy. And I'm not saying that in a bad way. I'm saying that through the lens of the 14-year-old, the 15-year-old, the child, the girl, the young adult, the guy, the parents who are all like so confused because nobody prepared us for this system. And nobody prepared us for this community. Neither does the system get prepared for what's to come. And so think about mental health, reproductive health, the invisible health illness. I remember when we talked about reproductive health back in 2006, we started with Bates College. We had students who were doing research on this. None of us understood what it was. It is a taboo. It's against the religion. It's against the culture. And we needed that because that was around the time that the Lucerne urban community was getting quite a bit of gained traction, and we were embedded at Central Maine Medical Center as cultural brokers, and we are seeing a lot of health needs. And what you're seeing is in real time the conflicts that this community and the systems were having. And a lot of women didn't know how to support themselves. They had no idea. So we partnered with Bates College. We partnered with family planning of Maine. I'm forgetting the name. We partnered with them, and what we did was we did a research, and what we did was looking at what kind of reproductive health do you need, what kind of ideas do you need, what kind of needs is there, and women didn't know what to do. And so what we did was we took a pre-survey and had data. And 6 years later, we did post-survey, and 100% of the women who were there were using reproductive health service of some sort. But they'll tell me, Fatima, don't say anything about it. I'm like, oh, we take confidentiality very seriously. Nobody's going to say. But that you could see for 6 years, we had to improve. We had girls who are faced with female genital mutilation that did not know how to use pads. They did not, that they would get clogged and they needed help. And how do you go to a doctor or a nurse or a primary care provider or a community health worker to say, can you help us out? They didn't even know what to do. They did not know what to begin. As a mother, when I had my first child, people were like, oh my God, what is this? And I'm like, okay, get the kid out of me first, and then we can talk about what the issues were. So there were so traumatic experiences, both on the provider side of things and the patient side of things. And so these sensitive, issues are issues that are really woven into our cultural norms. It is a stigma, it is existing power dynamics. And yet, as we know, in every culture, no matter who you are, there's always this idea of, we are the people. We are the man. We make the rules. We do this. And we are coming to a culture and a community where women and girls have voices. And those voices are not voices that we don't deserve. We as women and girls from our community have autonomy, deserve to have an autonomy over our bodies. And so one of the things that we really wanted to talk about today is, this framework of actively navigating them, right? We have comprehensive health sensitive framework at IRCM that we talk about. It is the vehicle that really helps us to assess multi-layered tools and hands. And Christina, you have your hand up.
Yeah, I'm sorry to interrupt. We are still seeing the poll question slide.
Oh, wow.
Just in case, I think you've gone on to the
I've
next
gone,
slide.
yeah, I've moved on. All right.
You also had a comment in the chat from Lori, saying how the reproductive health is a challenge. Also for American teen parents aren't happy with the questions either. Male HPV vaccine information was not received well by many.
Thank you. Yes, yes.
Yes, and we can see that the sensitivity framework slide now.
Can you see now? Yeah,
Yes.
thank you. Without my notes, right?
Yes, without the notes.
Thank you. So I'm going to go back to that question all right. That's true. That's true. That's true. So I can tell you, Lori, that a lot of our kids don't go through that either. It's a taboo. We have issues with vaccines to begin with. And then this is a whole different, and what I'm reminded of this is I keep weaving my old stories and the history and the approach here is when King Middle School in Portland said we are going to provide reproductive health services for middle school kids. Oh my goodness, we had three things that time. We had Lewiston School Department writing that the Somali community had all kind of problems with teen pregnancy, and that is a huge no-no for Somalis. Like Somalis having children out of wedlock, are you kidding me? If any of it's happening, we deny it, right? But then I'm sorry, no offense to Somali people, but it is what it is. We deny it. And but for the school to write a piece on in Sun Journal to say 19 girls got pregnant and we have an epidemic of teen pregnancy was a major no-no for us. We also had, these things were converging. We had King Middle School also saying that we are going to produce, we're going to have reproductive health services for young kids, middle school kids. That was a huge taboo. It was a huge no-no. We also had CMMC and and St. Mary's going through a number of different issues that were so sensitive that nobody can say it. And because I don't want to also identify people. And so this was a very trying moment for us. So our first thing was we're going to do outreach, community education. We did it in Hillview, we did it in downtown, we did it in Auburn. We did a lot of work, and part of it was to educate the systems. And so in that instance, Lewiston School Department met with us and offered an apology, because what we said was these were girls who were married. They're not married on paper, but we can attest to you that these girls were actually religiously married. Here is their meher, the religious ceremony that was done. So many people, and our kids are not born out of wedlock. So Lewiston School Department, we need you to apologize, which they did. They said, well, we're not connected to the community, so these girls who are 11th grade, 10th grade, 12th grade, and they're coming to school pregnant. And when we have teen pregnancy in our schools, there's certain services that we need to provide. But for a girl to just show up pregnant, that is a big thing to us. And so that created such a relationship and collaboration that supported those teen girls. And there were teen girls. In terms of the King Middle School reproductive health services, this mother had a consent form. She put it in her pocket. She came to us. We read it for her. She passed out. She couldn't believe. And then we had to educate the school to say, our daughters are not sexually active. Our boys are not sexually active. Is that true? I don't think so. Who are we to say in this setting, in this community, in this culture that is so out of control that our kids are going to align with our cultural lens? And that is what we're talking about. What we're talking about is this idea of parents are not happy, systems are not happy, communities are not there yet together. However, we've got a generation of children coming in the pipeline, and because of them, we must work together to be able to get culturally and linguistically and trauma-informed systems that really can support our kids. And I'm going to move fast, Christina, because I feel like I am talking a lot and we may be running out of time. Can you see my next slide?
The slide is still in the sensitivity framework.
Okay. I'm going to skip this chat activity. Is that okay?
Yeah, I believe there was still conversation about that.
Yes, yes. All right, so navigating sensitive health discussions with intercultural awareness. I think this section is able to define what makes certain health topics sensitive or controversial within our cultural context. Again, at our agency, we use this framework to introduce a practical tool for healthcare providers and so forth. And one of the things that we talk about is really communication and, sort of bridging the gap through intercultural communication framework, and that is in making sure that we have intervention strategies. We talk about narrative healing approaches. We talk about nonverbal communication interpretation. We really make sure that there's effective communication that's cornerstone of cultural responsive. And I think it's important to also understand that the communities that we serve are very resilient. They're very good at what they do. These people survived war-torn countries. They have survived a lot of trauma. These people are the most courageous, resilient, really hopeful people that you'll ever meet, because for you to come out of a war-torn country or a country that is not allowing you to live and to come here and to make something out of it is super important. So when we talk about our communities, I want to talk about our communities through the lens of resiliency, courage, and how we have a community power together. There's a lot of community unity that we provide. We struggle. Obviously, this is not our home country, but it's our home now. And what we do is to ensure that we are showing who we are, and that I don't want people to feel like, okay, they are just scrambling. No, actually, it's the other way around. We've made Lewiston Urban community a much better community. And so this framework provides concrete communications and interventions. We also emphasize on nonverbal communication interpretation, recognizing that there's a keen awareness of body language and tone, understanding cultural difference in communication styles are critical. I think when you are a person of color and you come into a white system, and that there's a lot of privilege there, making sure that your bias is really in check, and that you're not coming in very strong, because of course you are a provider, of course you're educated, of course you're providing services to me, but at the same time asking me too many questions, too loud. Even at times I feel like the interpreters sometimes have a hard time. That's why back in 2003 we introduced cultural broker services, because a cultural broker is not an interpreter. A cultural broker is an advocate, an educator, a liaison, the person who is really working between the provider and the client or the patient or the victim or the survivor. Again, a story here is, we had a particular case where there was a victim that had domestic violence, and she just had a baby, and that baby didn't have the lining between the air pipe and the windpipe, and so the baby was choking on the breast milk. And the Department of Health and Human Services did not have an interpreter. This was at Maine Medical Center. This is some 20-something years ago. And this woman came from a refugee camp. That's how she grew up. Maybe she was born there. I'm not sure about that piece, but she grew up there. She came to Lewiston. They put her in high school with no English, one word of English. So imagine being 16 years old, not knowing what to do. You're already 16 years old is a very difficult age to be in. And so she gets into a relationship, there's domestic violence, there's all kind of stuff going on. The child is in crisis, and the department calls police on her. Her child is removed from her. It will be 7 months before we get involved. And so at that moment, we wanted to have everybody to back off, to work with the department. We took the department to court. We had lawyers. And one of the key things that we needed to do was really making sure that this mother had an evaluation for her, a mental, psychological health evaluation. And we couldn't do that. There was no evaluation tool that was going to help her. So I came into the court and said, I am going to decline that and tell the court that they need to make sure the department has an appropriate tool. So we use a non-verbal appropriate evaluation tool. And in that setting, I was in the background. I was a cultural broker. There was an interpreter. The psychologist was there, and they were doing all of the stuff that they needed to do. And I will come in and explain and educate the provider, and then also educate the mother in that sense. And the psychological evaluation came back. It was okay. She was competent, and the judge ordered the department to bring back that child within 24 hours. By then, the baby was having seizures every minute. He wasn't doing well, and he did die. But what that did for us, to this day, Hamza was his name. To this day, I honor him all the time, because of that case, we now have very comprehensive child welfare collaboration with the department, where most of our kids and problems or all the stuff that's happening, they don't get removed very quickly without having resources in place. And then parenting education that are culturally specific was started because of that case. And so this nonverbal communication and interpretation and doing all kinds of things is super, super important. Okay, I am going to go very quickly. How am I doing for time?
Yeah, I was
Christine?
going to do a quick time check. There's 15 minutes left.
Thank you. All right, so building trust and addressing power dynamics, the role of cultural humility is super important. Beyond the techniques, the mindset is crucial. I think it's important for us to really look at cultural humility, the benefits. We have a very fantastic approaches that we do, willing to share with you that. I'm going to go very quickly. I'm going to skip this one too. Sorry, Christina. I'm gonna skip this one too. You'll have the slides. All of you will have the slides. Collectivism versus individual, the cultural collectiveness and the individual approaches are really super important in the healthcare approaches. I think it's important for us to really think about what does that look like? What does the individual look like, need, and what does the community need? I think both of them are very important. I'm not saying let's break up the community. I think our community identity is the strongest, I feel like, in the entire state. In the Somali community, in the African culture, you can just go into the community and say, you know what, I need this and this and this, and somebody somewhere somehow, will help you. And so I think that is a strength that we have. I think the thing that we're talking about is really meeting the individual through that lens and some other lenses and help that individual in a way that it really helps them out. I'm going to quickly go through there. I think there is that cultural divide that we have. The core divide here is the individual culture prioritizes the personal traits, independence, individual rights, self, expression and privacy and all of that. Now, my Somali community, my African culture, it's very different. It, really emphasizes on the group, right? What are the needs of the group? What do we need to do for the group? Who the independence is actually defined by the group. There is hierarchy, there's the elder system, there's all of this. And so it is a fundamental cultural distinction that profoundly impacts healthcare practices. If you go into a home, if you're a cultural broker, or if you're a community health worker, or if we bring in a family into a healthcare system, you tend to see providers really struggling what to do. They don't know. They want to talk to the mother. There's a child abuse case happening. Maybe there's sexual violence happening. They want to divide that, and you can see the conflict in real time. What you see often is this contrast of, this person's of age. Let me talk to this person. What happened to me when my kids became 18 and I am now there and saying, yeah, we need a physical. And they'll say, ma'am, you really need to leave because she can sign for herself. No, I'm the mother. How am I going to sign? No, she is of age. And those things are very offending. We get very offended. Why would you, but couldn't a provider educate the parent, right? The provider, the tool here is for the provider who has a relationship with this family, with this household, with these individuals, to prep them and to say, according to laws in this country, when someone's of age, we cannot share their information. Then you are aware of that. But for it to come on the day of, you're like, what? This happened to me. My daughter was going to college. She was 18. We're doing a physical, and they're telling me, you can't sign for her. We want to do this by herself. We want to do this. And it's very, very offensive. And so I think it's important for us to really think through, we as providers, what is it that we're trying to do? Again, this is the same thing, the values, the decision-making process, the collective, values, the individual values. Those are super, super important. They're still in here. Now you tend to see, we as parents really have that. We infuse a lot of that into our children. Are they doing it 100%? No, but you see the struggles of us trying to really maintain that. And I think what happens there is, I want young kids, right? Boys, girls, youth, young adults. It's important for them to really make decisions for themselves, as well as making sure that that cultural identity is there. And Christina, I think I may stop in a little bit to ask questions for just a second.
Sure.
Questions? Any additions? Sprint for the next slide.
I'm sorry, can you repeat that?
I wanted to stop here to see if there's any questions or any additions to what I'm saying.
Oh, okay. There are not any questions or comments in the chat as of now.
Bridging the divide for clients a client-centric care. I think that's super important. There is an inclusive empowerment and opportunity model that we do here at IRCM. And part of it is, we built a vehicle to ensure client-centered journey, holistic and anti-oppression service delivery. So there is, like here at IRCM, we have like what's called stability plans, and we put all of those things in one place. We also address the tension between the individual and the collective decision-making process. Our family systems are really, we have the engagement model that has both of these things into it. Okay, women's reproductive health. I think this is a very fantastic topic. It is. Oh, Christina, did you have something to say?
No, your mic goes off a little bit sometimes, and so, but we can hear you well now.
Oh, sorry. Can you hear me?
Yes, we hear you,
Yes.
Rona. So when you just go a little bit far from your
I
computer,
know.
yeah, and you need
Yeah,
to be a
thank
little
you.
bit close.
Thank you. So reproductive health, women's reproductive health, I've talked about this a little bit. I think there is a particular sensitive area where these cultural dynamics play out. And in women's reproductive health, it's really sensitive thing. I don't know that there is a particular maybe in the young people, maybe you can hear that, but in the culture, reproductive decisions are often communal. They're heavily influenced by family, community leaders. Someone my age, I cannot dare say, use reproductive health. It's really a taboo. This idea of see if we're functioning from a place where we do not have any reproductive health issues, if that is where we're functioning from, then you can see how a lot of us may not have access to that. Is it true for my kids, younger generation? No. But if they're going to do, because it's such a sensitive thing to talk about, and so much infused into us that is against the religion and against the culture, that really if someone is doing it, it's going to be behind the scenes. Nobody can say, you know what, I had too many kids and therefore I'm using birth control. You have to pick and choose your audience. Our models ensure that our cultural approaches to consent and agency, engaging multiple family members, are respectful while upholding the individual being. Like we have to separate people. If someone came to us and said, we are a sexual assault center, and so we deal with a lot of that. And so if someone came to help for help and for us to navigate them and center them around navigating that system, then we'll have to individualize that person and see what their needs are. Questions again. So we talk about scenarios. I've given a lot of stories. I think, a scenario here is a young adult patient expresses a desire for a specific reproductive health service, but their family, deeply involved in their healthcare, voices strong cultural and religious objections. How would you handle this situation to honor both the patient's agency and their family cultural context, leveraging the principles we have discussed from IRCM's models? I'm checking out. Yes, Sakia?
So I've definitely seen this scenario play out in real life with clients, and it's a tricky situation because number one, it says young adult, so that person has agency, right? Especially in the legal sense, they are allowed to make their own health decisions. They're allowed to navigate the health system the way they would choose. But that collectivist idea that the family makes these decisions and that they're not left alone to make those decisions can be really difficult, especially with I would say the younger generations, especially if they've grown up here. That kind of creates a contentious environment. So I think the most important thing is to facilitate a dialogue between the family. Um, there's this idea in the individualistic cultures where you kind of do things on your own and you don't sort of seek help or look to other people for support. And I think that's one of the strongest aspects of being part of a collectivist society. You can make your own decisions, but being able to consult with people and have conversations and work through and solve problems is something that I think everyone can benefit from. And so it would be really important to not only build that trust and have that relationship, whether that's through a community health worker, social worker, or someone that can help mediate, but being able to facilitate that conversation and at least begin that dialogue, I think is the most important thing. So that when it comes to this young adult making decisions for themselves, they feel empowered to do so. And the family themselves also feels as though they are being included in that process at least a little bit so that they don't feel isolated. So I think, yeah, it's definitely a tricky situation, but that I think that's how I would approach it.
Yeah, and maybe I think after this session, maybe we can all put our heads together, because I think the idea that I'm sort of beginning to formalize here and think through it is are there health topics and health education and scenarios like this that we can bring parents, meeting circles is what we call in our agency, where we can actually talk about sensitive issues. We talk about meeting circles, we talk about domestic violence, we talk about trafficking, we talk about sexual assault. But is there a step for families to be prepared, particularly when these kids are preteen, teenager? Because I don't think we have a lot of issues when the kids are younger, right? But it's this block of time where this independence that the child is seeking for, and the family pulling that back. But it's not only the family, to Zakia, to your point, it's also the community. It's also the community. This community does not tolerate none of this. Your body's changing. You are a young person. You not only is your body changing, but your mental health. There's all kind of things that we need. And so what you need is for your parent to be able to guide you, for your parent to be a backbone system, a system that can support you. Whether you disagree or agree, it doesn't matter. Your parent, it's better for you to get information from your parent than anybody else. Now, if that doesn't work, then you have other support systems like, cultural brokers, community health workers. Your primary care provider is also probably the best person that you can confide in if that support system at home doesn't work. But the idea that we have kids who are growing up in this country, they're going through a lot of evolutions, they're changing, and no community member and no family member is able to understand that, relate to them, support them through that process, acknowledge what the issues are, is extremely unheard of. And that is where I think our parents, have to really understand that you've got to understand and acknowledge that your cultural lens, my cultural lens as Somali mother, is not my daughter's cultural lens. And I've acknowledged that way, way back then, because it is important for them. Not that I'm not a Somali mother and there are things that bother me all the time, but I have to hold myself because I do not want my child to make mistakes. And that has been really, I'm going to check the chat one more time. Thank you. Thank you. Communities grow and evolve as well. I think that, yes, we try to hold on to cultural and traditional approaches. We definitely have to adapt and do this. And there are changes and time will change and all of us are going to change. But I think it's there. I don't think when young parents who have young children who are raising their children in this community, when they talk to me, I'm like, you need to prepare yourself. Because when the age of 11, 12, 13 gets, you're going to get into a crisis that you have not seen. And part of it is because the parent is not prepared. The parent is not prepared. Okay, I will go very quickly. And Christina, I feel like, we are getting into the last. So the invisible illness and system barriers, I think, that also is one of them. I'm just going to go through them very quickly. The unseen burden, there is a lot of conditions like chronic fatigue syndrome, many mental health conditions, which really lack that immediate measurable symptoms. And it's a very challenging thing. And nobody believes in it and nobody can recognize it. And when this kid or this mother or this community member is sort of cannot manage it, It's now like, what's wrong with her? No, the system wasn't prepared for this person, wasn't engaging this person, wasn't supporting this individual. The community wasn't supporting this individual. Again, I am talking to someone who grew up in this country, very confused. We lack a sense of identity. We lack the support system that we need. No parent, no community member, no system understands what our young generation go through. And that is the ugly truth. That is the ugly truth. I'm going to go through this very quickly again. Overcoming systemic gaps through, service delivery models, key components is very important. Vehicle for change is very important. I'm just going to go through it very quickly. I'm so sorry. These slides are going to be available. Really making sure that there is challenging, like we as providers, we as systems, are able to really deconstruct the techniques that are our direct approach to challenging inequities. Like it's important for us to really involve systemic changes. It's important for us to really have meaningful, impactful, and intentional approach to changes. Okay, systems try to do all kind of work, and it's a checkbox, which is great. But if you're not measuring your impact, if you're not measuring what is supposed to, how your changes are impacting the communities and involving that, I think you need to always come back to it. I'm going to skip through this one, and I know I've got 3 minutes. I feel so bad. Commitment to mapping, your action for change. We've got some things there. Practical takeaways. I'm going to go through this quickly. I think it's important for beyond tools, we advocate for actionable strategies that embody visions that we collectively create to transform care. This includes implementing care models, actively engaging the communities and the patients and communities in the design, delivery, and evaluation of your healthcare programs. Like you can't create something and tell me, here is what you need to use. If you want my house to be good and you're telling me, this is what you're supposed to do without you stepping into my house, I'm sorry, you're not helping me out. And so I think it's very important for us to really develop culturally responsive communication tools, making sure that we have MOUs in place, referrals in place, interpreters who are trained on these sensitive issues, our interpreters that do domestic violence and sexual assault.
Really? Yeah.
Our interpreters who do sexual assault and service delivery in terms of domestic violence. Years ago, we acknowledged that they needed that piece of work. And so training, community awareness, collaboration, partnership, checking your biases, all the things that we're not able to see, and really saying, if I was to help this individual and center this individual, where do I begin? If it's not you, someone else out there knows what to do. Seek for that, support that, look for that, collaborate, partner, and at the end of the day, that young person deserves a better opportunity, a better life, a better advocate, a better system. Because when they succeed, those young kids, we all succeed as a community. And with that, Christina, back to you. I know I ran out of time.
Thank you, Hatuma. I think that the last few words were a little distant, but I want to thank you for bringing this presentation, because it's really important to be part of this conversation. Thank you for preparing that presentation that we'll be sharing with all the participants, and they'll have all the details. So if we can quickly, we have we can go to the next slide. Axels, this is part of a learning series. And so the upcoming series, if you can go to the next slide, Axels, it has the next topic that we have for next week. We hope that you can join us. We'll have another presenter talking about this cross-cultural communication and how can we improve our communication with patients, with clients, so that it provides a better patient experience. And so if you can take just a couple of minutes to answer the evaluation poll that Axels is just pulling up. I know that these are all important conversations that really would take us many hours, right, and even days to dissect everything. But I, aside from inviting you to another session, I also want to invite you to look in the chat for a link to a registration. We're having an in-person conversation about how to better improve the patient engagement, and how do we build trust with patients, and so that patients can feel the trust to seek a provider, and that the providers are speaking the same language, right? That they try to really connect and understand patients. And so thank you for joining this session. You'll receive the recording, and you'll also receive slides. Again, you'll receive information also on the event that's coming up on September 12th. The link is in your chat. And we thank you for just staying a couple of minutes after the webinar, and thank you for joining us. Thank you, Fatima.
Thank you so much. Thank you.
Thank you all.
Take care.